So, hello and welcome to this webinar on rheumatology follow-ups, transforming outpatients. I'm Sue Brown and I'm the Chief Executive of the Arthritis and Musculoskeletal Alliance, ARMA, and we're an umbrella body that brings together patient and professional groups to work for better health services for people with musculoskeletal conditions. We're delivering this webinar today in partnership with the NHS elective care programme, which is working on the commitment in the long-term plan to reducing face-to-face outpatient appointments. And today we're going to be looking at what this might mean for rheumatology. We're going to start with a brief overview of the programme, and then we're going to hear from 3 speakers who've got practical experience of doing this. But I'm going to start by introducing Amanda Woolley, who is Policy and Implementation Lead for the Elective Care Transformation Programme, to give us an overview of the work on transforming outpatients. Amanda.
Hi, thank you, Sue. I'm just going to get my slides up for today. I hope you can all see that. Firstly, I just want to say a huge thank you to Sue for agreeing to host the webinar with us today. I really appreciate it. We do a lot of webinars through the Elective Care Transformation Programme, and I know what an awful lot of work and how anxiety-provoking they can be. So I'm really thankful for Sue for taking that on. Those of you who are familiar with the Elective Care Transformation Programme also will be aware that we think it's really important to work in partnership. So it's really, I'm really grateful to Sue for working with us and for us to be continuing to build links with ARMA. I just wanted today to give a brief overview of the Elective Care Transformation Programme and why we have put this webinar on today. So just to say again, my name's Amanda Woolley. I'm Policy and Implementation Lead for the Elective Care Transformation Programme at NHS England and NHS Improvement. Our programme has been running since 2017 with the aim of improving elective care pathways. With this year and the publication of the Long Term Plan, our objective is very much around supporting local systems to plan and implement transformation programmes that will deliver that reduction in face-to-face outpatient attendances. We work nationally with expert clinicians and key stakeholders to develop, coordinate and share resources, including around alternative outpatient models and technology that assist that. And we also work very much to support local transformation of outpatient services. And we do that through working with core implementation sites. So at the moment we have 8 implementation sites that we're giving intensive support to, and another set of sites where we're giving more light touch and moderate support to. And then we coordinate we coordinate collaboration between local systems and also at a national level to address common barriers to implementation. So some of the common things that come up are around digital infrastructure, are around tariff and payments or workforce, and so we're working to coordinate on responses to some of those challenges.
Amanda, at the moment, we're seeing is your final slide.
Oh, that's peculiar, because that's not what I'm seeing.
Ah.
Hang on a moment. I'll stop and I'll start again, sharing again, and see if that. Sorry, everybody. I want you to be able to see what we're doing. Okay. Can you see that now?
That's now.
Can you see that?
Slide, yeah.
Okay, that's the slide that I was just talking through, and I'll move swiftly on. But just to say, of course, the long-term plan set out the ambition to reduce outpatient attendances by 1/3 over the next 5 years, and that's really around reducing unnecessary trips to hospital for patients in order to provide care closer to home and at the time that it's needed, rather than simply based on routine, and also to support new models of care that better integrate care across the system. So why rheumatology today? So there's sort of 3 drivers for this. Firstly, MSK is one of our focus specialties for 2019-20 in the elective care transformation programme. The majority of our work around MSK has been supporting the service pilots and evaluation around first contact practitioner for MSK services. And so looking at rheumatology and rheumatology follow-ups in particular is a great opportunity for us to put a bit of a focus on the other end of the pathway along on follow-ups and long-term care for people with chronic conditions.
So that slide seems to have moved on. Is everyone else
okay?
Yeah.
Can you see it? There should be a slide that says, why rheumatology?
No, we're still on transforming outpatients.
Oh dear. Right, I think I might have to do it like this. Can you see it now?
No.
No?
Do you want to try show, because have you gone to slideshow?
No. I don't think it gave me that option. I'm sorry. Application window. I only have the option to share my screen. So do you want to share, have you got my slides, Sue? Do you want to share them?
Share those. If I can manage to hit the right button, and then.
Okay, well, while Sue's getting those up, I'll keep talking. It's just, I'm just doing a lot of reading out loud, I promise, so don't worry too much about it. So MSK is one of our focus specialties. We also have a virtual development collaborative. So a development collaborative is a way of bringing together teams and individuals who are working on the same problem or challenge. In this case, the challenge to transform outpatient delivery, to share learning, share challenges, and provide some peer support. So we have our 8 implementation sites, but we also, through our community of practice, which I'll speak about later, provide support to local systems across the country. We have 3 of our core implementation sites. So 3 of our 8 sites have a focus on rheumatology for this year. We also had a lot of activity on the community of practice discussion boards around rheumatology pathways in particular, and around follow-ups and some offers to share learning from new ways of working that had been implemented. So it seemed like a really good opportunity for us to do a webinar and take that forward, and hoping that there'll be a lot more discussion coming out of the webinar following this. And that very much fits in with the third reason, which was just around the existing good practice that does exist in rheumatology around different models of outpatients. Really key interventions and changes in the way that outpatient services can be delivered are already evident in rheumatology. So we're going to hear about patient-initiated follow-up and some remote monitoring approaches. It's also really good examples of different use of workforce in rheumatology services already. So I think rheumatology really has a lot to offer other specialty services as well, in terms of lessons learned for how we can do this in different ways of working. And I'm hoping today is a kind of an initial opportunity to start understanding what's possible and what the barriers are to universal adoption of some of these practices, both within rheumatology and in other specialties. So for me, what I'm really hoping that everybody on the webinar today will be able to have in their mind as they listen to the presentations. I'm really delighted to have the 3 speakers that we have today. I think they've got a lot of really exciting and interesting work to share with you around their rheumatology services. But my key questions are, can you implement this in your area or service? And if you did, what do you think the challenges would be? And what support would be beneficial at a local, regional and national level from NHS England and NHS Improvement, but also from other system partners? And the other thing is just to raise again around our community of practice. So we have an online future NHS collaboration space that acts as our hub for our elective care transformation community of practice. We have sections by specialty and also by interventions, and lots of discussion forums. We run regular webinars and are really kind of trying to be very responsive to what people need in terms of information, guidance, and helping people network with others who are working on similar problems and trying to find solutions. We'll also be having all the resources that are highlighted in this webinar. We'll easily link to them through the page there. And in the slides here, there are links to those workspace pages. And also, I think when Sue sends out all the recording and everything after the webinar, these links will be on there as well. So if you're not already a member of the Elected Care Community of Practice, you can sign up by emailing the address there, and that will be in the post-event email following the webinar. And it would be really great to continue some of the discussion on the forums there. I know I've been having trouble sharing my slide, but I wonder if I can just share my screen. I might be able to show you the community of practice. Would that be helpful?
Give it a try.
I can give it a try.
Yeah.
Give it a try. So that's sharing that one. So this is our workspace here. This would be the landing page. We tend to have news on this carousel here, and it'll take you to any webinars that are coming up or any recent events or key documents. So for rheumatology, you might go specialties, and then there's a section around MSK. You can see here, you can access the section around first contact practitioner. The webinar details will all be there. Our MSK handbook, which is a couple of years old now, but may still be of interest to you. And then the MSK forum, which has lots of discussions already there, but you can access the forums. There are also forums around particularly patient-initiated follow-ups or pathways. So there's been a number around imaging pathways in MSK. So you can have a look at those as well. And we do try and link across the forums when we see that there's kind of key areas that people might want to be interested in. But I think that's all from me.
Brilliant. Thank you very much. And yes, the links to all those resources will be in the email you should get on Monday, along with the link to the recording. So I'm now going to invite Will Dixon, who is Professor of Digital Epidemiology, Honorary Consultant Rheumatologist at the University of Manchester and Salford Royal, to talk about his work on remote monitoring in RA. Will.
Thank you. So can you hear me all right and see the screen that says remote monitoring?
Slides, yeah.
Yeah, okay.
Yeah.
So see if I can advance the slides, which I can. So thanks for the introduction, Sue. So I'm a rheumatologist at Salford Royal in Greater Manchester, an epidemiologist at the University of Manchester. And most of the projects that I'm involved in try and bridge these two worlds. The Remora study, which is a research study that we ran over a 2-year period, was doing just this. The primary driver was the problems that we face in a consultation where you'll recognise the challenge. You ask the patient how they've been in the last 6 months, and then they try and recall that 6-month period and disentangle their symptoms from everything else that was happening in their life and communicate that clearly to you in a very short period of time. We thought that the increasing adoption of consumer technology might help us address this, and so the Remora study was a smartphone app that was co-designed with clinicians, patients and researchers to collect daily symptoms in patients with rheumatoid arthritis. We're trying to kill multiple birds with one stone. So first of all, we were interested in how this might support self-management, only through the process of symptom tracking without anything fancier alongside it. Secondly, how it would support clinical care, and uniquely we had integrated this patient-generated health data into the electronic health record where it was visible in the usual system. And then thirdly, how that same data might support research. It ran in 3 phases. So the first phase was understanding the views of these different stakeholder groups of clinicians, researchers, and most importantly, patients. And then having understood what these different groups would want to be collected, we then designed the app alongside patients. We had a second phase where we just made sure that the data flow worked from the app through to the electronic health record. And then in phase 3, we tested the app over a 3-month period, asking 20 patients to track their symptoms on a daily basis. We had a consultation at baseline, a consultation at 3 months. We audio recorded those consultations, and we had interviews and focus groups before and after the period of app use. After the phase 1, we came up with a question set, some of which were daily, quick and easy questions to answer about things like pain, sleep, function, well-being on a scale of 0 to 10, a categorical response for morning stiffness. So those were really quick and easy to do. Slightly more intensive questions on a weekly basis. So following some training, we had people self-report tender and swollen joint counts, a global assessment. We asked them about flare. And then on a monthly basis, we asked about the HAQ, the disability questionnaire. These are just screenshots of what the app looked like. It was nothing fancy, but it was clean, simple, and easy to follow. So there were sliders in the daily questionnaire, so you could score between 0 and 10. Steppers in the weekly questionnaire if you were scoring a tender and swollen joint count, and then radio buttons for the categorical responses in the monthly HAQ. So some results from Remora here for self-management. Patients said it improved the visibility of a previously invisible disease, even between them and their family. So this patient had been tracking her symptoms with her partner standing over her shoulder in the evenings. And she said, I'm not one that moans about being ill, but because it was every night, my partner would be looking over her shoulder and saying, how are you scoring today? And why didn't you say? And it did make more communication between us. So they planned their lives accordingly, whereas previously she would have kept that quiet. In clinical care, as I said, this is where we were pretty unique in integrating the data. Here you can see this picture of where the data are graphed in the Allscripts electronic patient record at Salford. I'm going to show you 2 discussions between the clinician and the patient. The clinician's in black and the patient's in colour. This was after a 1-month period in our phase 2 testing. So the first patient, last time I gave you a steroid injection, how have you got on since then? So that's the doctor in black and the patient in red. The injection was great. By the time I was going home from work later on that day, I was feeling so much better. And okay, how have you been since then? I've been fantastic. In fact, I feel a bit of a fraud for your research because it has just been steadily good. Any symptoms at all over the last month? No, other than the fact I just have a few limitations as to what I can do, but no actual pain. And so let's have a look at your graph. And then we talk through the graph as a shared decision aid in the clinic. So the pain's between 0 and 1 for the first 7 to 10 days. And then you did have a couple of days where the pain was worse. And the patient said, yeah, I'd forgotten that. And you have to remember that this is a patient who has been doing remote monitoring and is coming to an audio recorded consultation about remote monitoring where we're only asking about their symptoms over the last 1-month period. So there's really kind of limited hope that people will be able to remember their symptoms in the last 6 months. Here's the example from patient 2. The doctor, again, there's quite a significant day-to-day fluctuation, but it looks, as you say, that the extent of the fluctuation is going down. And the patient says much more eloquently, it's funny on this, you can see the trend, can't you? This was a patient who had been on a biologic drug for 1 month prior to their baseline consultation. They thought it wasn't working. We said, let's hang on for another month and see how you get on. At that 2nd month visit, she also thought it wasn't working. And then we looked at the graph together and changed the clinical decision that we would otherwise have made and kept her on it, recognizing that things might be improving. So in the interviews afterwards, patients were very positive about the app, a great thing, a great idea, a brilliant thing, and can't wait until it's out there properly. The data entry was near complete. More than 90% of possible entries were complete in our 20 patients. Patients felt that the data collection captured the moment, made the fleeting symptoms visible, and picked up changes that would otherwise have been missed. And those symptom graphs made it easier for a shared conversation with the data saying it for you, providing evidence and personalizing care. So that was the clinical care aspect. For research, the numbers are relatively limited as to what we can do with this so far. But in the future, the idea is that we may be able to automatically identify flares, identify periods just prior to flares, and that gives you the opportunity to intervene in a timely way. There's a publication about the Remora study that's online currently in rheumatology. You can access it online. It'll be in the print edition soonish. And then just to finish off, some of the future opportunities, really our to-do list following the Remora study. This was a bespoke research study in a single site, and it is at present not scalable, and we need certain infrastructure to make it scalable. So we have to be able to prescribe it in a time-limited consultation. Patients have to be able to go home, download an app, authenticate as who they say they are. That then has to lead to the right person being linked to the right record. If they give appropriate permissions, which requires an e-consent module in the app, it has to go into a repository for patient-generated health data. It's not right that it should go into an electronic health record where the provenance is from the clinician. And then it needs to interoperate not just with one electronic health record, but with any agnostic of the provider. So that's our kind of technical to-do list. And we just received funding from the Greater Manchester Digital Fund to do this over the coming 12 months. And once it's scalable, there are then some other things that we need to evaluate. So what are the clinical benefits, not just for early adopters, but for early and late adopters, both clinicians and patients. We've only so far looked at how we use this data at clinical visits. We're interested in how we might also use them in between visits. So things like scheduling outpatient appointments according to clinical need, enabling remote care like nurse-led phone lines with that data, expanding the data collection beyond self-reported scores to images, sensor data, and other things. The app could reasonably give digital interventions and perhaps data-driven. And then there's a whole question about funding, sustainability, a commissioning and procurement framework. So that all needs to be established because that just doesn't exist for remote monitoring currently. So just to very briefly summarize, we believe that this has given proof of the transformative value of integrating patient-generated health data into clinical consultations. It's not happened much in rheumatology, but nor has it happened in other clinical specialties either in the UK or internationally. And I genuinely believe this has huge opportunities for self-management, for clinical care, and also for research. Thank you.
Thank you very much, Will. And I'm now going to invite Tracy French, who's a clinical nurse specialist at the Rheumatology Department of Bristol Royal Infirmary, to outline their direct access system. And Tracy, I'm going to try to share your slides for you.
Okay.
Okay.
Yep, should I start?
Yeah.
Okay, hi, I'm Tracy. I'm a nurse specialist. I work at Bristol. I'm going to talk about direct access, which is essentially a system of patient-initiated follow-up. I wasn't involved in the original project, but I've worked with it for many years. So it was based around the idea that traditionally routine reviews in rheumatology, the majority of our reviews were for patients with rheumatoid arthritis, but often we weren't seeing patients at the right time when they needed to be seen. We were seeing them when they were well, but then when they were flaring, we were unable to give them an appropriate or timely review. The graph, sorry, I can only see my presentation. I can't see what you're putting up, Sue. But the graph just shows the flare of the disease in relation to symptoms and CRP, and then the red lines at the top reflect the routine outpatients that were being given probably at sort of 3-month intervals. So you can see some of them do coincide with when patients are flaring, but most of them don't. So the idea was to try and address this, and that was where direct access came in, and there was a randomised controlled trial that was done in Bristol, and hopefully you can see the screen where it's published in the BMJ with all the authors there. So the design of the trial, it was called Direct Access, and it was comparing this new idea for patient-initiated follow-up with routine hospital care. It was for patients with rheumatoid arthritis of more than 2 years duration. It was powered to ensure detection of any clinically important reduction in the outcome of pain. So it looked at clinical status, but it was also looking at whether money could be saved and obviously whether it was acceptable for patients. Initially conducted for 2 years, but then extended out to 6 years. Then the slide just shows you the numbers of patients in each group. and the drop-off and follow-up. So the randomisation was to 2 groups. So one was the control group, which is usual practice that you see your rheumatologist say every 3 months, for example. You know when your next appointment is. If you have a problem in between that 3 months or 6 month appointment, you then, at that time point, the access was back through the GP to the rheumatology secretary, who spoke to the consultant, then made the appointment. So a slow process. The direct access system, you would see your consultant, you wouldn't be given a follow-up appointment. You would just then simply contact through the nurse advice line when you felt you needed to be seen, or if you just needed some advice about how to self-manage. The GPs could also call the advice line if they needed help or they wanted to refer a patient. The aim was that the patients could be then seen if they needed an appointment as deemed appropriate by the nurse who spoke to the patient. They would be seen within 10 working days in a direct access clinic, ideally with their own consultant team. Of course, the MDT could also refer into both services as appropriate throughout the RCT. So the results looking at clinical outcomes was there was no difference between groups. So for pain, disease activity and early morning stiffness, they were equal. And then looking at the use of resources and the savings, the visits were significantly reduced for both primary and secondary care. So it suggested significant savings and better use of resources. Then looking at how patients felt about the direct access system, there was a significantly higher approval from patients from the point of view of satisfaction and confidence with direct access versus the control group. That was really reassuring. So the conclusion of the RCT is that using direct access, the care that was provided was not at any clinical detriment to the patients, that there was good satisfaction and confidence, that it empowered patients to have a degree of self-management, but there was a reduction in resource and costs. So we then went forward and implemented direct access into our practice. It was rolled out into our routine service. Steering group was established. The criteria for patients going into the system, so not all patients went into it. It was only ones that had stable disease of more than 2 years duration. They had to come in to have a little education program, have information leaflets, talk through how it all worked. Obviously, they needed to consent to do it, and it needed to be, the consultant or the medic had to say, yes, this is appropriate for the patient, that there weren't any other issues that, would preclude them joining DA. So the system was set up, the direct access slots with the consultants were ring-fenced, and when it was first started, it was a direct access clinic, so a whole clinic just for direct access patients on set days of the week for each consultant. The education program was set up and the leaflets and so on were made. The helpline, I can't quite believe this, but this is at a time when there weren't advice lines in rheumatology, so it was established specifically to run the direct access system. And then from the RCT, it was noted that the sort of average time patients, if they didn't have a flare and called in flare, they would call about 18 months, 2 years, just to kind of touch base and have a catch-up. So it was agreed that there would be a 2-year review in a nurse-led clinic for every patient to check that obviously they weren't, having flares that they weren't reporting, but also to maybe discharge them from the service where appropriate or reduce their medications, whatever, but that we were seeing them every 2 years. So direct access worked really well for 14 years, but we're in a bit of a different place now. There's a lot of pressure on our new appointments. They've more than doubled. We're struggling to meet our EIA targets. Routine non-EIA news are waiting quite a long time, and we've got a significant backlog for patients, so for routine reviews, and then that's obviously having an impact on the rest of the service. And obviously what Amanda talked about at the beginning, we're hoping to try and think about how we can reduce face-to-face outpatient attendances moving forward. So our direct access system is under pressure and has been for the last probably 18 months. Instead of waiting 10 working days, patients are waiting 5 to 6 weeks now to be seen. So we're not able to provide the care that we were when we first set up the service. We have lost the ability to ring-fence slots for direct access patients. So if patients are ringing, they're not on direct access, but are struggling because they're on the overdue routine follow-up list, they're getting put into these slots, and that's just, it's causing problems. We're sort of at breaking point, really. We've lost continuity of care. Initially, the patients were seen by their own consultants team. there was continuity for both the clinician and the patient, whereas now people are just being slotted into any kind of clinic, and again, that makes for a longer and more tricky consultation most of the time. And we're just very aware that the pressure on primary care has meant our patients are much more easily able to access us for a much quicker response than they are primary care, so we are being inundated on our advice line. So our challenge is our patient expectations are high. We were delivering an excellent service, which we are now unable to deliver in the same way, and obviously they struggle with that, which is completely understandable. The time spent on the nurse advice line, I'm sure everywhere, is the same. It's more than a full-time role. It's not funded at the moment. So when we're trying to get more staff to work on the advice line, I'm writing business cases, but we're only getting paid for direct face-to-face clinic time with patients at the moment. So trying to get enough staff to man the advice line and run it appropriately is very difficult. This is combined with the fact that obviously when direct access was set up, patients, we didn't have biologics. That, I think most of our consultants feel that patients now have got a lot more comorbidities, a lot more stuff going on, so often can be a little bit more complicated to manage. Our local share care policy means that if patients are on disease-modifying drugs, they have to remain under our care in secondary care, which we feel is probably not necessarily appropriate, that primary care could manage them, which would save money and possibly be better for patients. Sort of things to take away, learning points I would say from running the system is that ring fencing the slots is essential, forward planning, allowing for holidays and so on. At the moment we're looking at maybe setting up direct access clinics that run every week, so we've got a fixed number of slots regardless of which clinicians are here, because the problem is that though we planned the number of slots we thought we needed, we actually often aren't able to have those slots available for various reasons in the service. And I just wanted to finish on a patient quote, because I don't want to sound negative. I think the service, working with it for many years, works really, really well and does actually sort of tick a lot of the boxes for what Amanda was talking about. But we just need to be able to, change and adapt with the current environment we're working in. But from a patient's perspective, the advice line is always the top of the list when we get feedback from patients. And I think the system itself allows patients to self-manage and to feel that they're partnering in their care rather than just receiving what we can offer them. So it is good, but we just need to tweak it really to make it fit for purpose now. Thank you.
Thank you very much, Tracy, for that. Really helpful. And I'm now going to ask our final presenter, which is Toby Garrood, who is a consultant rheumatologist and clinical director for specialist ambulatory services at Guy's and St Thomas's Trust. Toby.
Hello. Not going to work. There we go. Can you see my slides?
Yes.
So I'm just going to talk about three projects which we've been running here, each of which was born out of specific problems which we'd faced. The last is remote monitoring, which I'm not going to dwell on because Will is the expert in that and has spoken very well about it. The first of this is very simple. These are very simple. It's the question. It's the problem of running a helpline, which we're all required to do for good reasons. But the problems we've encountered with, I think, are the problems that others have encountered, is that it is the source of some frustration for clinicians and patients, because you're leaving messages on an answering machine without any particular ideas when you're going to get phoned back. And it was a frequent source of complaints from patients that we didn't get back to them, but it turned out that we usually did, but they were unavailable, understandably, if you don't know when you're going to get called. So, and we found that the non-completion rate for calls, so the non-return rate, was around about 30%. So the idea was, well, can we do this better? And we had the idea of, it's a very simple idea, there's nothing complicated about it, of establishing an online booking system for this. So we found a company that could provide this. And the beauty of this was that we had it up and running within a week. From idea to inception, it was a week or two. So it took very little effort, a relatively little outlay to get this established. So this is the way it works. So the nurses have access to a dashboard through which they can make appointments available, set the frequency and so forth. Patients are directed to this page from our website. We still have an answering machine, and then they can choose appointments. And these, at the moment, we're making these available about 48 hours in advance. We do find they fill up quite quickly. So patients will click on one of these times, say who they are, what the problem is, and then we will phone them back at that time. This is the numbers we've been having. This is up to about April. It's been fairly static since then. So we have around about, slightly more than about 500 appointments are made available a month. We have either 1 or 2 sessions of 10 to 12 slots a day, each of which is 10 minutes long. And what we've shown here is utilization rate is good. So utilization rate is roundabout or higher than 95%. And it's more and more of our helpline calls are now being directed to this service. And we've been looking at how we nudge patients away from the answer machine onto this. It doesn't work for everyone. Obviously, some patients don't have access to computers or smartphones, but for those that do, it works well. And what we found is that it works well. Our non-completion rate has dropped through this system down to about 3%. So almost all calls booked through this happen with the patient. And the other thing is we now, it's associated with a tariff because these are now pre-booked calls. And we've made the case, for each call we record whether we think this would offset a face-to-face appointment or some other encounter within the health system. And so for those patients, we've now tracked a tariff. So it pays for itself. And we're now rolling this out across multiple services in our directorate, dermatology, clinical genetics, and elsewhere, not just for this, but also for booking blood tests and for booking calls with administrators. The second thing I want to talk about is the problem of referrals. Now, this is a long-term frustration for all of us working in rheumatology or any other secondary care service, and that's the problem of not getting the right information from referrers, and it's been the source of much frustration for many years. But it's largely because referrers don't always know what we want to know, and we try and solve this through forms, which don't always deliver what we think they're going to deliver. And so this is an ongoing issue about making sure we get just enough information from the referral to make sure we get the patient into the right pathway. So we had this idea that, well, what if we ask patients what's wrong with them rather than worrying about too much about going backwards and forwards to GPs? So the hypothesis was that patients could add useful information to the referral process. So the hypothesis was that the GP would send a referral as before. We would send an electronic questionnaire out to a patient on receipt of that referral, and then these side by side could be used for triage, thus allowing us to either arrange pre-appointment diagnostics or to put them into the correct pathway. So this project was run by one of our Darcy fellows, Winnie Chen, and we're just going through an evaluation phase at the moment. The first issue was, how do you get capture? How do you make sure that enough patients respond to this to make it worthwhile? And this is a really interesting process with a lot of work with patients who's taking a user-centered design process. And we started off with a baseline rate of about 35%, but through optimization of the look and the language of the messages, and for instance, using patients' first names, making sure the message was from the NHS rather than from a random number, and the language itself had a significant impact on capture rates. Included in that is the timing of reminders. So they now get an initial invitation and they'll get 2 further reminders. And what we've managed to do is get that capture rate up to about 80% plus. So it's been consistently above 80% as we've made various changes to the language of the question of the reminders. And what the questionnaire consists of is a number of sort of validated questionnaires, so including the ACR fibromyalgia diagnostic criteria, the ASAS inflammatory background criteria, some questions around inflammatory arthritis, and also the GAD-7 for anxiety and the PHQ-8, which is the PHQ-9 without the suicide question with regards to depression. So this is now used to inform clinical consultation. This is imported into the patient's record. And just to give some headlines, so we're going through an evaluation at the moment, some headlines. So just on paper, so the diagnostic criteria of fibromyalgia require clinical assessment, but on paper, of the patients that responded to this questionnaire, about 74% meet the paper threshold for fibromyalgia, just suggesting a lot of these patients do have significant chronic widespread pain with somatization symptoms, which suggests there's quite a significant issue with the demand with regards to non-inflammatory pain in our population. About a third of patients have moderate to severe depression as assessed by the PHQ-8, and about 25% have moderate to severe anxiety. And we now have psychologists embedded in our service to whom we can direct patients. And we're just looking at breaking down this data. What we found, of the patients with moderate severe depression, almost all of them do have generalized widespread pain. So the hypothesis now is if we combine these questionnaires into an algorithm using machine learning techniques, we might actually be able to produce an algorithm with sufficient predictive value to actually use this to stratify patients with specific pathways. So for instance, inflammatory versus non-inflammatory presentations. So this is how we see it working. So we're now doing that evaluation, and we hope that we'll be able to stratify patients with sufficient accuracy into pathways. So one of which, of course, is advice and guidance back to the GP. I think there's a significant unmet need, at least in our area, for community-based pain clinics. A lot of these patients probably don't need to come to rheumatology. Of course, there's routine appointments and important in the early inflammatory arthritis clinics. But also, it may well be the case that many of these patients could come and see first contact practitioner of some sort of physiotherapist. We have physiotherapists seeing new patients already. The bottlenecks, certainly in our service, are GP patients getting to their GP and getting that referral in the first place, as we know, which is the big challenge around getting early arthritis patients in, and also routine appointments. The bottlenecks at the front door, not so much for us around the early arthritis, just the demand on the service. So if we can somehow offset this and direct patients to more appropriate services and pathways, or to do diagnostics in advance, meaning they get the most value of that first appointment, we should be able to create capacity. And just downstream of this, I just wonder whether we may be able to stratify maybe a small subset of patients to whom a direct referral might be applicable. There may be patients who have early inflammatory arthritis who we could skim off, who we could actually see before coming to their GP. And most of those patients may well end up being directed to their GP. But if we could somehow take a little bit of that load off general practice, who at the moment seem to be the gatekeepers for almost everything, that could add a significant value both to us and to them. And just the final one, we also have been testing a remote monitoring platform, which I'm not going to dwell on too much. The focus for us will be more about how we manage patients between appointments. The initial working hypothesis being that if we have patients on remote monitoring, we can see those with low disease activity or remission with rheumatoid arthritis less frequently than we might otherwise do. We have about 100 patients on this platform at the moment. It's being mediated through SMS rather than app. And we use the RAID, as Will described. And when patients deviate significantly from their baseline, they are directed to the aforementioned telephone booking service for advice and guidance from our nurses. And we're also just thinking about, well, how does this fit into the wider system? So in the context of an integrated care system, which we're now part of, how might remote monitoring and digital health help us to make best use of the resources, particularly there's such pressure on all of us individually as services. So we're about to embark on a project supported by our local commissioners and our local health innovation network, whereby patients will be sharing this platform across multiple organizations. There'll be a central triage hub, and within which patients will be triaged if flaring back to the local teams. It's just to see whether, A, we have the trust between us to actually share such a system, but also whether we can start to look at how we can make better use of the combined resources that we have. And that's my final slide, to say thank you to everyone who's been involved with this, particularly Mel Martin, who's been heavily involved in the remote monitoring platform, and Winnie, who's our Darcy Fellow.
Brilliant. Thank you very much, Toby, for that. And so that's the presentations, 3 really useful, I think, and interesting presentations. And now it's over to you. If anybody has any questions for anyone, just reminding you of the questions that Amanda was posing to you at the beginning. Are there things there that you can see that you could implement in your area or your service? What sort of challenges might you face? Now's a good chance to ask the people who've done it if they've got any ideas for solving those challenges, because they probably came across them as well. And also, what sorts of support might be beneficial from local, regional or national NHS England and NHS Improvement. Any questions or any thoughts on that, do put them in the into the Q&A box. This could be the first ever ARMA webinar when no one had any questions.
I just I have a couple of questions, Sue. Just while people are waiting or thinking of what their question is. Oh, there's one that's popped in. But I just wondered about. So firstly, I just wanted to say thank you to Tracy particularly for sharing, because I think if people are looking at patient-initiated follow-up, you know, this is your crystal ball into how it might turn out. And I think that's a really good point about patient-initiated follow-up means that patients will still need to be seen, and we still need to think about capacity for them and those processes. And there's a lot of learning there. But I just wondered from Will and Toby, in terms of the remote monitoring and risk stratification kind of pieces of work, what do you see as being the kind of the big challenges in developing that work and getting that implemented at scale, both in your own systems and potentially in other areas of the country as well?
So maybe if I start, Toby, I think one of the big challenges of doing it at scale is getting the infrastructure in place that allows that to happen. I outlined briefly what I think that infrastructure needs to be. There are lots of different providers for different bits of that, and so you then need to have interoperability standards that allow you to plug different providers into different parts of the system. So I think the first one is the app providers. There's a lot of different app providers out there that do symptom tracking, and that's fine, but there need to be standards whereby that data can then flow into the NHS. For that to happen, we need to do user authentication, so that we know the right people, a certain person links to the right record. The NHS is doing work on that, and there is the NHS login program that's being used in NHS app, and that's being shared with app providers, but that's just at the start of its journey, really. The patient-generated health repository is something that has never been needed before, but we need to put that in place now, and there are likely to be different providers for that, and therefore standards for interoperability required. And then it needs to integrate into any electronic health records, and so the EHR providers have to be a bit more flexible than they currently are, I think, to allow the data to flow in, or at least to have a view from their record into the repository. So there's technical challenges, and then the kind of categories of other challenges are that we need to solve the concerns of patients, things like if I'm entering my data, will it be looked at? So we need to ensure that the clinicians are going to actually bother to look at the data. We have to empower them with sort of trust that their data are being managed appropriately, the kind of security and governance around that. We need to solve the providers' concerns. Clinicians are obviously going to be worried that if you start deluging them with a whole load of patient data, their lives are busy enough already and they don't want to be having extra work to do. But I think we've shown that providing a visual summary of how somebody's been over the last 3 months is actually sort of time neutral and potentially time saving, because you spend the first 5 minutes of a consultation trying to understand that anyway. And then there are technical challenges that we need to overcome, all of the governance issues. If we are making decisions based on patient data, how is that recorded and tracked? So there's lots of challenges, but we need to just slowly work our way through them. The problem is that you have to overcome all of them all at the same time to make it successful.
So I don't know if you can see the questions there. There's questions about do you use any tools or measures like patient activation measure to identify who's most likely to be a completer, and also is the patient data monitored continuously?
Yeah.
And who does the monitoring?
Okay, so patient activation measure, we didn't include that. So no to that one. The patient data does come in continuously, but in our Remora 1 study, we were clear with our participants that we would only be looking at it when they next came for a consultation. But I think in terms of the future for what remote monitoring data can do, it may be that we can do more with it in between visits, but we need to be explicit about what that is so that everyone's clear.
Great, thank you. And then we had a question about, this is all about encouraging non-face-to-face support, but the QOF is still incentivising primary care towards face-to-face. Have any of you got any comments on how you might be addressing that?
What's the question?
So it's about primary care still being incentivised towards face-to-face. Are there any issues around the different incentives between what you're trying to do and what other bits of the system are trying to do?
I think it's complex. A lot of the incentives are around tariff, and so at the moment, I think well, there's a lot of anxiety around exploring new ways of working, and people are put off by the current tariff structure, so particularly people are still paid by results. But I think it's for us to define how the future should look and what works, and then on the back of which we look at negotiating the financial models around that. So I don't think that should be a disincentive to doing this. I think for many patients, it's clearly an advantage not to be seen face to face. And I think NHSI have landed on this figure of £17.50 an hour is what it costs a patient on average to come to hospital if you factor in work time off work, travel time, so forth and so on. But in the context of the previous question around what are the challenges, and I think, for us, a lot of it's around the culture of this. And I don't think it's enough just to stick digital, non-face-to-face on top of what you do already. It's about how you frame that within the wider wraparound care of patients. And it needs to be core to what you do rather than an add-on. And we did a lot of work with patients to explore with them what do you want from digital health. And it wasn't so much what the app looks like and the bells and whistles. It was wanting to feel looked after and safe and cared for, which is a slightly harder and more nuanced thing to solve. So for instance, the feedback. So one of the things we do with our, we do make sure patients get recognition of feedback. So if they do deviate from their baseline score, we will contact them. The other challenge for us is capture, and how do you get patients to fill this in regularly? Because the perception of patients all the time is this: what's in this for me? Filling in a questionnaire month after month after year after year. We know the patient enthusiasm drops off over time. So we've looked quite hard at the pain points in patient care. So, for instance, blood monitoring for patients on DMARDs or biologics, and we've prototyped and started to build a system whereby patients are texted reminders to get blood tests done with a system which will then look for the results and text them their results and ultimately deliver their prescription electronically. That's a bit of a way off, but we're starting to work on that. And the other big challenge I think nationally, as I said at the beginning, is how we share all this, because I know that lots of us do lots of different things. There's an awful lot of overlap, but I think we need to be far better at sharing and admitting particularly what's gone wrong and what's not working. We tend to hear about the successes, but not about the failures. And I think it's really important that we all learn from each other. And we're very keen. We're not pressed what we've got. We're very, very keen to share everything we've got, including even the platform, the code, whatever it may be. But I think there's a huge amount we could learn from other people as well.
Right, and there was also a question about whether users were involved in the design of the patient-facing applications. Did you involve patients in the design, and if so, how?
Well, we extensively. So we started with bits of paper. So we'd sketch out what this might look like, and we'd show it to patients, look over their shoulders. Then we'd start to produce non-functioning prototypes, get patients to interact with that before we started building functioning prototypes, and we'd watch patients interact, we'd video patients interacting. This is all about the user, so absolutely.
Yeah, I completely agree. We had a patient and public involvement group where we then had lots of qualitative work with the patients before we ended up with an app that we actually put into live testing. And as Toby says, unless you understand the perspective of the user and you design it for them, it's just not going to work.
Okay. And a question specifically for Tracy. If you were going to roll out the direct access pathway again, what are the key elements you would change to help mitigate some of the problems you've experienced?
So I think the first thing, we had issues with IT in that when we set up direct access, we had one system, we switched to another system, so it meant we lost track of how many patients we actually had on direct access. So I think I would plan ahead if I was starting from scratch to be able to highlight who was a direct access patient and very easily access the numbers of them in the system, so that you can then plan ahead and ring fence slots. I think that's the key thing really, is that if you want to keep this in your service and run it effectively, it needs to be protected from the other pressures that are on the service for new slots and so on. I think I would be very clear about getting funding to run the advice line, particularly the part that this only works if you've got nurses to answer the phone to patients. because not every patient that rings needs an appointment. And so if you can sort of get some payment for the value of that work, then that's going to help the service run more smoothly. I think I would also encourage more of a focus, probably than there was initially, on self-management and directing patients to some of the other stuff that the other guys have been discussing, really, to sort of self-managing and helping patients to sort of do that first before getting in touch with us. I think that probably should be focused on more, yeah.
Okay, great. We're just about coming towards the end of our time. Amanda, did you want to say anything to sum up or respond to any of that?
Just a couple of quick responses to some of the things that have been said. Firstly, if you're not already a member of the community of practice, please do log on to that and join. That is absolutely the place to go, and share the work that you've been doing. We're really interested to see and hear about things that maybe didn't go quite as well, and what we can learn from that and how we can continue to improve and make that available to other people so they can learn from things that have worked and things that have been a bit more challenging. Particularly around the point on tariff and payments, people might be interested in a recent Development Collaborative webinar, which was particularly around payments and how the new contract is hopefully going to work, and that consultation process and the direction that that's going in. So that's all on the community practice, and you can look into that, and that will all be linked up in Sue's email that will come out afterwards. But I just want to say a huge thank you to Will and Tracy and Toby for sharing today. It's really great to hear all the work that you're doing, and a really great start to kind of hopefully what's an ongoing conversation around rheumatology outpatient transformation.
Right, and thank you all very much. Thank you very much for joining. I hope you found that useful. You will, as we've said, get a link to the recording, so please do share that with anyone else you think might benefit. Thank you all very much.
Thank you.
Thanks.
Thank you.
Thanks, Sue. Bye.